Your time starts now. You are a lower track oncology specialist doing bladder cancers and prostate cancers in your unit. One of your colleague has seen a bladder cancer patient, evaluated, did TURBT. The result is G3PT2 high grade bladder TCC in the histology. Being a lower track oncology specialist, you are taking over her care. How are you going to take it further?
I'd ensure that this patient has been discussed in the urology MDT with full staging scans completed in the form of a contrast-enhanced CT scan of the thorax, abdomen and pelvis. I'll also need to assess her comorbidities and obtain the recommendations from MDT. And provided she has no metastatic disease, then the treatment options would be to offer her a radical cystectomy, bilateral pelvic lymphadenectomy, and urinary diversion, or radical radiotherapy, and both of those are neoadjuvant chemotherapy. I'll then see her in clinic myself with a urology cancer nurse specialist and confirm her age, her history, her comorbidities and her general fitness for surgery, including whether she's on any anticoagulants, and also whether she has a smoking history. I'll then perform a chaperone physical examination to note her BMI. I'll examine the abdomen, looking to elicit any abdominal loin pain or tenderness or any previous surgical scars, and I'll also perform an internal vaginal examination to evaluate for the presence of any palpable masses.
Okay. How are you going to stage her?
I'll stage her. So she's already been staged histologically, and I will stage her for the presence of distant metastases with a contrast-enhanced CT scan of the thorax, abdomen, and pelvis.
Okay. Let us assume she has no lymph nodes or any chest involvement. What is the role for neoadjuvant chemotherapy if she opts for surgery?
So according to the ABC meta-analysis, adjuvant chemotherapy with either gemcitabine and cisplatin-based chemotherapy or with the MVAC regime produced an absolute improvement in overall 5-year survival of 5%.
Okay. And what is your next steps? Let us assume you refer the patient for neoadjuvant chemotherapy. After the chemotherapy, what is your next steps?
So my next step will be to repeat her staging CT scan and see if there is a response of the tumour to this, but also to ensure that she has not developed any metastatic disease. And in terms of next steps, I will then counsel her about the procedure if I've not done so before, and talk to her about the benefits, risks and complications and post-op care of undergoing a radical cystectomy. If she, yes, that's what I'll do.
Okay, so how are you going to plan the radical cystectomy?
So I will ensure that she has a baseline blood test taken with a pre-op assessment to include a full blood count, urea and electrolytes, a group and save with a cross-match of 2 units on the day, and also taking preoperative MRSA swabs, an MSU and a COVID swab. I will ensure she has up-to-date imaging, and I will also ensure that she's seen by a stoma nurse if the plan is for a urinary conduit formation, and to go through with a patient how to live with a stoma and manage the stoma bag.
Okay, so what is your plan? After radical cystectomy, how are you going to reconstruct the ureter?
The preferred means of reconstructing the ureter would be with means of performing a Wallace anastomosis. This consists of constructing a Wallace plate on the posterior aspects of the distal ureters, and then anastomosing them onto the proximal end of the ureter of a ileal conduit, which would be harvested from terminal ileum, going approximately 20 centimetres from the ileocecal valve, and using a 20 to 30 centimetre length of bowel.
Is there any role for neobladder reconstruction?
So a neobladder, an orthotopic neobladder could be offered to patients if they are very much resistant to having an ileal conduit, and if they feel that it would psychologically be too much for them to live with a conduit. However, there are contraindications to this. For example, if there is invasive urethral disease or if there is extensive CIS. Other contraindications include an inability to perform ISC, because this is required post-op, and also if the patient has a GFR of less than 60, if they have urethral sphincter incompetence causing incontinence, and also if they've had preoperative radiotherapy or the presence of inflammatory bowel disease.
Why in a patient with eGFR less than 60, neobladder reconstruction is contraindicated?
So this would be because one of the potential complications, or one of the potential late complications arising from neobladder construction would be renal failure due to the associated metabolic effects and risk of recurrent UTIs.
Okay, so what are the methods by which neobladder can be reconstructed?
So I'm aware of the Studer technique, which uses harvests terminal ileum approximately 30 centimeters from the ileocecal valve, and a 60 centimeter segment is harvested. The distal 40 centimeters is detubularized and anastomosed onto the urethra, whereas the proximal 10 centimeters is formed into a tubular portion, and this is where the ureters are then anastomosed onto, again using a Wallace plate technique.
Okay, what are the long-term complications of neobladder?
The long-term complications include a risk of malignancy at the ureterointestinal anastomosis. There is a long-term risk of renal failure. There's a long-term risk of metabolic complications, including B12 and folate deficiency if terminal ileum was used, a long-term acid-base electrolyte imbalances, bone resorption, and there are also specific urological complications, including a ureterointestinal anastomotic stricture, formation of stones, mucus production needing ISC, and recurrent UTIs.
Okay, what are the methods by which radical cystectomy could be performed?
So this can be performed using an open approach, laparoscopic, or a robotic assisted approach.
What is the evidence behind robotic assisted?
I'm not aware of the authors, but the robotic assisted approach has been associated with a significantly lesser blood transfusion rate and bleeding, and a shorter length of stay in hospital. However, in terms of the oncological and longer term metabolic outcomes, there's been no significant difference compared to the open approach.
What is your plan for the lymph node dissection?
So my plan will be to perform a standard bilateral pelvic lymphadenectomy, but this will be taking lymph nodes from the true pelvis, which will be from the obturator, internal iliac, external iliac, and the presacral groups bilaterally.
Okay. Is there any levels of lymph node dissection depending upon the tumor?
So I'm not aware of a dissection depending on the tumor itself, but I'm aware that the levels of further extended pelvic lymph node dissection would go up to the bifurcation of the aorta, and a super extended pelvic lymph node dissection would go to the level of the inferior mesenteric artery.
Okay, well done. We will complete there. Again, nice flow, no concerns, clear answers. I will say absolute, complete, full mark. So you have nothing to really concentrate or to improve on. The only few things what I will advise is in the pre-op preparation, apart from the stoma nurse, you can involve the enhanced recovery protocol nurse. Remember that for both radical nephrectomy and radical cystectomies, and also sometimes like nail cancer or any other radical surgeries like retroperitoneal lymph nodes for testicular cancers, etc. And when you are giving the exit strategy after radical cystectomy, when you're discussing radical cystectomy itself, bring the options of open laparoscope versus robotic assisted, and in my practice I do open, nothing wrong in it. You can say in my practice I will do robotic assisted radical cystectomy with open conversion for ileal diversion or neobladder reconstruction. So when discussing the surgery itself, you can bring yourself the three methods available and what you normally perform, so that the examiner will just keep in that level, but for theory's sake he or she may ask you about the robotic assisted, what is the advantage. And similarly, the ileal conduit versus neobladder, instead of me asking you what is neobladder, you can say there are two options of reconstructing the ureter, ileal conduit and neobladder. In my practice I will do ileal conduit or the other one. So you can choose whichever you want, and the examiner may be happy to take it through what you are doing. But just for theory's sake, they may say, okay, I know you are not doing neobladder, what are the methods of reconstruction, what are the long-term effects, etc. They can ask theoretically. Otherwise, I think you're absolutely fine. We try to do a kind of covering all the scenarios. So started from visible hematuria, evaluation, non-muscle invasive bladder tumor, muscle invasive bladder tumor, including chemotherapy. The only few things which we haven't touched is the radiotherapy, which mostly I will say 90% won't be asked, because they want to test you in the urology rather than the radical radiotherapy, which is not also that common in bladder compared to the prostates. I'm happy with your progression. Very good. Well done. Any questions you have before we complete?
No, I don't think so. I think the main thing will be probably the nerves on the day, but I'm sure that'll settle by the time we get into the swing of the after the first few stations.
See, in exam, at any point you will talk only like 10 plus 10, 20 minutes in a stretch. I am purposefully doing as much as possible 3 10-minute sessions, so that your capacity or the vital capacity and the mind flow is now easily fixed for 30 minutes. So doing 20 minutes will be more easier. So it's like we are training you for a good 20-meter dash, but in the actual test you are tested only for 100-meter dash. So you will feel more easier actually in the exam compared to what you're doing with us. Good. Well done. So if there are no further questions, have a nice rest of the day. I will keep in touch with you with maybe one slot for tomorrow. If you are able to take it up, that's fine, but be flexible. The choice is yours.
All right.
Good. Have a nice rest of the day. Bye.
You too. Bye-bye.